Hello, ladies and gentlemen, and welcome to our continued series of lectures in Medical Surgical Nursing 4, BMS 2201. My name is Samuel Buga from the School of Nursing, and we shall continue with our online series on neurological disorders. And quick outline of our sort of continued course so far that we hope to continue with. We've covered cranial disorders, cerebrovascular disorders. We'll continue with a bit of degenerative disorders, central nervous system tumors, and eventually finish with status epilepticus. All right, so let's begin with brain and spinal abscesses as part of disorders around the nervous system. A brain abscess is defined as a free or can have a capsule around it, encapsulated collection of infectious material within the parenchyma of the brain, and it can be between the dura and the arachnoid mater, linings of the subdura, or between the dura and the skull, what we refer to as epidural abscesses. Now, those are brain abscesses. Spinal abscesses typically will occur in the epidural region, while other types of abscesses like intracranial subdural abscesses are usually due to streptococcus and can cause a purulent drainage to come from these abscesses. Remember, we said you can also have a capsule around it. It can result from pus building up between the meninges, or pus that comes from the meninges into the middle ear, the mastoid, the sinuses, or even septicemia, infection within the blood. Epidural abscesses typically involve an infection within the cranium, coupled usually with a bit of encephalitis, commonly due to mastoiditis, sinusitis, or even head trauma, or can be acquired through a craniotomy as part of surgical interventions. Spinal epidural abscesses. Remember, we said most spinal abscesses would arise from the epidural. So epidural abscesses occur within the external spinal canal to the dura mater. So epidural will penetrate or may seed from blood arising from septicemia or from adjacent tissue that is laden with infection. Intermedullary abscesses, more common in children, pediatric population, and will be associated with lumbar sacrodermal sinuses. Fungal brain abscesses, usually HIV positive people and immune compromised patients. Clinical manifestations of abscesses, both spinal and brain abscesses. Usually, clinical features would involve a headache that has a dull ache, a headache that you feel is heavy, right? Increased intracranial pressure, so what we mean by ICP there, resulting in nausea, vomiting, fever in about less than 50% of the cases. Neurologic findings, you could get a bit of hemisensory and paresis deficits, aphasia, right? Poor coordination. Ataxia, aphasia is language impairment. Ataxia, issues to do with coordination and balance, right? That means there's a problem with the cerebellum. Seizures, frequently present, right? Dental abscesses, sinusitis, otitis media may be present, and even mastoiditis, as we mentioned before. Signs and symptoms of epidural emphysema include severe headache, fever again, mucorigidity, all right, and a positive canine sign. A canine sign, we're going to look at a quick diagram as a follow-up to this slide to show what this means. Patients with intracranial epidural abscesses would present with fever, lethargy, and even severe headache. Spinal epidural abscesses specifically may be evidenced by severe back pain, back aches, fever, headache, lower extremity weaknesses. Patients can tell you, look, I feel like my legs, not as firm as they used to be. paralysis even, nuchal rigidity again, positive canine sign, and local tenderness around the spinal lower lumbar region. So, canine sign. See this young child here? Once you flex the leg at the pelvic region here, and then with the other leg is extended, as you try and extend the leg from a flexed knee position, so there's resistance here, right? Rigidity, coupled with pain. That is what we refer to as a positive canine sign, okay? And you can read more, but remember, a positive canine sign can also be as a symptom of other neurological conditions. Now, let's go back to medical surgical nursing, look at what are the nursing interventions. Specifically, when you think about pain, you need to relieve the pain, administer pain medications, right? NSAIDs and so forth. Provide comfort measures, such as a quiet environment, away from a lot of noise. Positioning is very important, okay? Especially with the head slightly elevated. Just by placing 2 or 3 pillows on the patient's back. Assist with hygiene needs in case the person has severe weaknesses that they cannot move about. Provide passive relaxation techniques, soft music, and so forth. Right. Next is promoting thought processes. This is when you think about nursing, diagnosis, thought process, positive mind frame, and so forth. Frequent monitoring of vital signs is important. Monitor the level of consciousness. That's what we mean by LOC here. Orientation to place, time, and the surroundings. Seizure activity. Report any changes that might be present. Like, you sense that this person has severe dull sort of headache that might signify increased intracranial pressure. Administer medications as ordered, and always prepare the patient for diagnostic tests in time. Minimizing neurological deficits is another nursing intervention. When you think about deficits that may present, especially we know the nervous system is interpretation of stimuli presented. So maintain a safe environment with side rails raised up, especially in pediatric population to avoid, collapsing over. Frequent observation, very important. Evaluate cranial nerve function, very important, all the cranial nerves, and report any changes, any manifestations, if you think they have language impairments, aphasia, ataxia, and so forth. Refer the patient for occupational therapy. Very important to help them, transition back into society, into normal functioning. Speech therapy, very important. We say that aphasia is a common problem. Another rehabilitative specialist. Reduction of anxiety is very important. In human beings, getting worried is a normal thing, right? All these problems, people are, frantic up and down. COVID-19 is a problem. Reducing anxiety, prepare the patient if the patient requires surgery to drain the abscess, for example. Explain the postoperative progression in nursing care. Very important. Please, it's important as nurses, as medical practitioners, do not give patients false hopes. Tell them it might take a process, especially if there's severe nervous impairment. Now, moving away from that, I want us to look at degenerative disorders. And specifically, I want us to focus on Parkinson's. I do, however, would like you to go also and read up on Alzheimer's. Alzheimer's is the leading degenerative nervous system disorder, right? Parkinson's comes in at a pretty close rate in second place. So what is Parkinson's? It's a chronic progressive neurologic disease, debilitative, and is sort of responsible for loss of control and regulation of movement. Key characteristics, as we shall look at here in this individual nicely here, is tremors, right? Bradykinesia, rigidity, and postural abnormalities. Important to know is that Parkinson's is less commonly affects people in younger ages. However, it has been documented in young ages as young as 20 years. But it's more of an advanced age disease. Second most, we've mentioned that, neurodegenerative disease. So let's look at the quick symptoms of Parkinson's. Motor skill symptoms, bradykinesia, as we've mentioned, a mask-like face with decreased blinking, right? Degrading and other degradation of fine motor skills, right? Someone cannot do basic, like a finger to thumb opposition test, such as that. Vocal symptoms, we'll look at that, rigidity and postural instability. You know, they cannot walk in a straight line. Again, coupled with the tremors, hand tremors, and they have a very firm grip, right? Give you a handshake, very firm, but they're also very slow to raise objects up. Walk and gaits, difficulties, dystonia, very important, defined as repetitive muscular movements. Let's look at non-motor skills, Mental behavioral issues, especially with self-perception. Sense of smell is also altered. Sweating and melanoma, quite common. Gastrointestinal issues associated with weight loss, sexual anxiety, and so forth. And then we have pain, which we shall look at in the next slide. So please note the motor skill symptoms, non-motor skill symptoms. Now, what is the pathophysiology of Parkinson's? Associated with dopamine, a deficiency in dopamine, especially due to degeneration in the substance nigra. Sorry, there's a bit that has been cut out there. But the etiology is viral, all right? It can be due to pesticides, exposure to toxic pesticides, herbicides even. Methylphenyl tetrachloride. It's abbreviated as MPTP, okay? Welding fumes or repetitive head injuries. Now, MPTP, important for you to know, is that it causes permanent Parkinson's-like symptoms, all right? So, diagnosis of Parkinson's disease is usually based on the clinical profile. But we can do other tests like a PET scan, as we shall look at in the next slide. Observation, I said it's based on clinical features. We may do a bit of imaging studies to rule out other disorders. Physical assessments of the upper extremity, elbow flexion, extension would reveal rigidity when you're trying to extend this upper extremities. Sensory motor assessments of grip reveals, like I had mentioned, an abnormally high grip force. They shake your hand, it's, firm grip. But again, a longer than normal ability to complete lifting objects, all right? Particularly with lighter loads. We said we can do a PET scan, which is positron emission topography. Favorable response, especially if, for example, you've queried the clinical features, and then you think, okay, let's see if levodopa, administering levodopa will help. If you see positive sort of response to levodopa, then Parkinson's, right? Nursing interventions associated with Parkinson's. Important because of loss of motor coordination, fine skills is associated with improved the nursing intervention will be the need to improve mobility. So encourage daily exercise such as walking, and this goes out to everybody. Walking, riding a stationary bike, or even swimming, or even basic chores around the household like gardening. Advise the patient to do stretching and postural exercises. Wake up in the morning, stretch, right? The most important exercise, especially in old people, is tell them to wake up in the morning and stretch properly, right? Encourage the patient to take warm baths and receive massages, especially around joints because of pain. Instruct the patient to take frequent rests, because of fatigue and exhaustion. Posture exercises, walking techniques to sort of offset, they have what we call a shifting gait. All right, they never shift like this as they walk. So instruct the patient to walk with sort of a broader based gait to give them support so that they don't fall over. Ensure that the patient has a conscious effort while swinging arms and other basic exercises around the household. Nutritional status is the next key nursing intervention. Teach the patient how to think through the sequence of swallowing, right? Not just subconsciously, but also consciously. Because closed lips, teeth together, assist them with swallowing, and lift their tongue up to allow the food to go down. Instruct the patient to chew deliberately and slowly. Remember, fine motor skills are affected here, associated with other conditions like bradykinesia. Tell the patient to make a conscious effort to control accumulation of saliva. Very often, they have a lot of saliva around the mouth. Patients should use secure, stabilized dishes and eating utensils. And also make suggestions for smaller meals, additional snacks, and tell them to monitor their weight. Communication ability. This is when you're thinking in more advanced stages of the disease. Suggest referral to a speech therapist in case you think aphasia is a problem. Teach the patient facial exercises, grimacing, smiling. Very important. Exaggerate pronunciation and speak in short sentences to help them, because sometimes they may present with a stutter. Tell them to exaggerate their pronunciation and short sentences so that they don't have to speak so many words that might then cause or affect their speech. Right, I talked about facial muscles, smiling, frowning, grimacing, or even puckering. Puckering is, just put your lips together and then extend them out. Prevent constipation. Again, based on the gastrointestinal disturbances. Encourage intake of moderate fiber content in food. Increased water intake, very important. A raised toilet will help them during defecation process, and encourage your patients to follow a regular bowel regimen. Now, that is Parkinson's. Please remember I said read on Alzheimer's and other degenerative neuro disorders or neurodegenerative disorders. Now, let us look at two neuromuscular autoimmune disorders, one being Myasthenia Gravis and Guillain-Barre Syndrome. And we'll start with Guillain-Barre Syndrome. Henceforth, we shall refer to it as GBS for the sake of this lecture. Now, GBS is an acute, rapid, progressive, ascending, inflammatory, demyelinating polyneuropathy. It's a lot to go on, right? So let's look at the words here. Very important is it's acute, rapid onset, progressive, usually starts in the lower extremities upwards. Inflammatory, ascending inflammatory, demyelinating polyneuropathy, affecting the nervous system. It affects the peripheral sensory and motor nerves. Most frequently, it's acquired demyelinating neuropathy, usually presents. GBS is characterized by, very importantly, muscle weakness, especially ascending muscle weakness, affecting gait, affecting walking, affecting all these postural musculoskeletal related activities. It affects usually 1 in 100,000 people, but it causes significant debilitative events. It can be identified quickly, and then we initiate treatment as quickly as possible to decrease life-threatening complications. Now, the complications here, ladies and gentlemen, are associated if it gets here. Gets around the respiratory system, right? That means cessation of breathing, cessation of respiratory activity. What follows next? Death, right? So, occurs a few days following symptoms of respiratory or even digestive system viral infection. Maximum weakness occurs within the first 3 weeks after symptoms occur, with 30% of these will have residual weakness, even after 3 years. 30% of these cases never completely goes away. It has a recurrence rate of about 3%, but once it has occurred, it's important to sort of ensure that you let these people know that, look, these are the preventive measures that you should take. Right, mortality results from respiratory failure, as mentioned. Autonomic disturbances, very frequent, sepsis, complications associated with immobility. And this occur at a rate of about 5%, despite intensive medical care. Now remember, our resources, our health system resources as it is, are strained. And not a lot of people can meet the cost of intensive care required for Guillain-Barre syndrome. Now this, ladies and gentlemen, this badly drawn woman sort of shows what GBS is about. Ascending paralysis that is progressive, right? So I'll just quickly jump to what it presents with. Weakness, ataxia. I know this is not very legible, right? But hopefully you can get access to the notes once we send them to you. So weakness, ataxia, bilateral paresthesia, and progressive paralysis that is ascending. These huge black to yellow sort of arrows are indicating progressive paralysis upwards. Remember we said complications? Number one key complication is respiratory failure from progressive ascending paralysis. Now, how do you diagnose GBS? Histology. History and neurologic exam. Look at signs of progressive weakness. Decreased sensation, and even a decrease in deep tendon reflexes. This I know we covered in physiology, so we know what they are. Lumbar puncture for CSF examination, cerebrospinal fluid. Complete blood cell count will show an increase in white blood cells, leukocytosis. Electrophysiological studies, where available, you can conduct nerve conduction velocity studies, which will show a decrease in conduction velocity of peripheral nerves. What is the management? High dose of immunoglobulins. This will reduce the severity of the episodes associated with Guillain-Barre syndrome. ECG, monitoring, very important, and treatment of cardiac dysrhythmias that might present. You can give analgesics and muscle relaxants, right? Intubation and mechanical ventilation if you're thinking there's respiratory paralysis and subsequent respiratory failure. Let's quickly delve into myasthenia gravis. More common, right? It's a chronic autoimmune disorder affecting neuromuscular transmission in the voluntary skeletal muscles in the body. It usually occurs due to an antibody-mediated attack against acetylcholine receptors at the neuromuscular junction. Together? Right, so there's loss of acetylcholine receptors, which then leads to a defect in neuromuscular transmission. Cardinal features, most important, muscular weakness and fatigue. Remember, acetylcholine is an important neurotransmitter around the NMJ, or neuromuscular junction. Pathophysiology of myasthenia gravis. There is depletion of these acetylcholine receptors due to the antibody-mediated attack that we mentioned. Now, in about 90% of patients, there's no specific cause. But genetic makeup is a predisposing factor. In about 25 to about 30% of cases, we have a genetic association of myasthenia gravis. There's a reduced number of acetylcholine receptors that results in a diminished amplitude of what you call end plate potentials. Right, we've covered excitable tissue to look at muscle tissue. We've covered the nervous system, and we know the profile of nerve conduction around the neuromuscular junction. So, reduced number of acetylcholine receptors will then reduce the amplitude of this end plate potential. Failed transmission of the nerve impulse now to the skeletal muscle would result in a decrease in the muscle power, muscle contracting and relaxing power. And this is clinically manifested by extreme fatigue and muscle weakness. Now, patients with myasthenia gravis have serum antibodies to acetylcholine receptors. Now, here's sort of, rather negative bit about it is that women are 3 times more predisposed to myasthenia gravis than it affects men. Clinical features, right? We'll go through this quickly. Extreme muscular weakness and easy fatigability, we've mentioned that. Vision disturbances associated with diplopia and ptosis from ocular weakness. Facial muscle weaknesses caused by muscle-like facial expressions. Dysphagia from weakness of the laryngeal and pharyngeal muscles. Proximal limb weakness with specific weaknesses in small muscles of the hands. Respiratory muscle weaknesses that might include the diaphragm. Now, that then would severely be life-threatening, could be fatal. Then we have enlargement of the thymus gland due to production of these acetylcholine receptor antibodies. Right, let's look at diagnosis. How do you diagnose myasthenia gravis? Serum test for acetylcholine receptors antibodies, IgG1, IgG2. We can conduct electromyography, EMG testing, which will reveal a decreased response to repetitive nerve stimulation. CT scan to assess for an enlargement of the thymus gland. We say because of these antibodies. Quickly, let's mention management. Oral anticholinesterase drugs like neostigmine, we know this from our pharmacology. First-line treatment for mild myasthenia gravis helps to enhance neuromuscular conduction and transmission of the impulses. Immunosuppressive drugs such as prednisolone is usually the treatment of choice when weakness is not adequately controlled by this anticholinesterases. Right? We can conduct thymectomy surgery for those people with a tumor or even hyperplasia of the thymus gland. Right? So, in case of what you call a myasthenic crisis, crazy, widespread muscular weaknesses with fatigue, immediate hospitalization for intensive care is important. Airway management with mechanical ventilation, or even putting the patient on a vent, could be one of the measures or interventions we take, with vigorous sanctioning, oxygen therapy, postural drainage, and percussion and vibration. You can even conduct a tracheostomy to help with ventilation and respiration. Neostigmine IV in case of myasthenia crisis, and as well as discontinuation of anticholinergic medications until we improve the respiratory functioning. Now, this we can give atropine, right, to counteract the activity of these anticholinesterases and thus decrease the secretion of these cholinergic or cholinergic antibodies. Right, so ladies and gentlemen, that is a quick overview of degenerative neurological disorders. We've also looked at other conditions besides, even autoimmune disorders like myasthenia gravis. We've looked at GBS, a bit rare, but it's important. It's beginning to appear more now, again associated with viral, even bacterial infections in the GIT. I would like you to go back, read on nursing interventions for myasthenia gravis, specific interventions, dependent on specific nursing diagnosis that you might be able to pick up for myasthenia gravis and Guillain-Barre syndrome, right? And we hope to continue with the next series of lectures to cover more neurological conditions and finish with status epilepticus later. Don't forget to continue reading on integumentary disorders associated with the skin and so forth. With that, thank you very much, and you've been a wonderful audience.
These televised lectures supplement our robust online learning going on our MKU online platform. You can view more on our televised lectures via our online platform. We are in a digital era, and Mount Kenya University knows this. The following are the steps to follow so as to complete your online application. Download the application form from the website www.mku.ac.ke. Attach copies of your academic certificates and ID. Pay the application fees via M-Pesa pay bill number 270988. Your ID is the account number. 2,000 shillings is the charge for a postgraduate. You can also deposit in the bank accounts provided on the website. Then email all the above to apply@mku.ac.ke.